It's my pleasure now to introduce Dr. Mahmoud Mosli. Dr. Mahmoud Mosli is Assistant Professor in King Abdulaziz University Hospital. We're glad to have him back as an expert in inflammatory bowel disease. His lecture today is about how to treat to target in inflammatory bowel disease. Mahmoud.
Thank you, Mr. Chairman. I'd like to thank the organizing committee for inviting me to speak today. I'm going to talk about treating to target in inflammatory bowel disease. So the areas we're going to cover today are mostly related to choosing the target, why we chose the target of mucosal healing, and is it feasible? Can we actually reach it? How and how soon? So this is the same first slide that Remo used. I'm going to start with it. This is a theoretical illustration of a patient's disease natural course. And as you can see, the gut damage highlighted in the red line is driven by cycles of inflammation. Inflammation that is mainly uncontrolled with time. So early intervention might be successfully helpful in preventing complications. Sorry. So why do we aim for tight control? Similar to other, excuse me? Sorry, I just need help with the slides. It's just moving by itself. تحرك لوحدها. بس بتحرك لوحدها. It's just an audio. بس كان في حاجة مهمة بس. This is the case we might need إنك تقدمها تطور يعني step by step. Okay. إيه لأنه كل مرة هي just moves by itself. Okay. It's maybe أنت حطيت له timing. ما حطيت شيء. طيب if not working, you can just present like this, like one by one. Is it fine? Yeah, that's fine. Okay. So similar to other chronic diseases such as hypertension, type 2 diabetes, and rheumatoid arthritis, failure to achieve tight control might result in future complications. Now, certain advancements in treatment and insights into the changing disease endpoints has led to improvement in disease management plans, specifically a treat-to-target approach. Now, how do we choose a target? The target must be reliable, responsive to treatment, and valid. The word valid means that it correlates with the gold standard, or it's an objective measure of disease activity. So what options do we have? Symptoms, endoscopy, histology, or imaging, or even biochemical markers, similar to the ones that Remo had been talking about. So starting with symptoms, as you can see, results from REACT, for example, were negative. And I believe, for example, that these negative results were mainly driven by the subjective primary endpoint of the Harvey-Bradshaw Index. So most of us know the CDAI, and if you look closely at the items that make the CDAI, you'll find that they're not specific to IBD per se, or Crohn's disease per se. They're actually mostly symptoms that can be attributed to IBS symptoms. So why is it wrong to use symptoms to evaluate CD? Well, they're subjective, they're non-specific, they don't correlate with objective measures of disease activity, and there are alternatives that exist that are better. This is a nice cohort study analysis of 91 consecutive patients that either had IBS or Crohn's disease. When they measured the CDAI scores throughout the follow-up time, the mean CDI score were actually not different between the two groups. In fact, they were higher in the IBS patients. Again, this figure shows how CDI scores do not correlate with endoscopic scores based on the CDEIS. Now, it might not be the same thing for ulcerative colitis. We do know that there is a correlation between symptoms and endoscopy. However, whether or not these measures are reliable or reproducible and responsive is still questionable. Hence, we don't use it really to monitor disease activity on a daily basis with full confidence. Now, if we decide that endoscopy is not the perfect way to evaluate disease activity due to cost, availability, and theoretical risk of perforation, we need to choose surrogate markers that we can rely on with confidence. Now, candidates include biochemical markers such as CRP, fecal calprotectin, and stool lactoferrin. Additionally, we can use radiological measures such as MRE, CT scan, and ultrasound. If we start with fecal calprotectin, Remo had talked about the different applications of fecal calprotectin, but I'm going to focus on one indication, which is evaluating disease activity during the time of follow-up, and whether or not the results reflect mucosal healing. Now, this is a meta-analysis that we performed and was published last year. We pulled all the studies that looked at fecal cal in evaluation of disease activity in IBD. What we found is that fecal calprotectin and stool lactoferrin are fairly sensitive markers. As you can see, sensitivity is about 88%, specificity is 73%. So you can use fecal calprotectin when you're monitoring disease activity to rule out the disease. So if your fecal cal is negative, that is really helpful, and you might not need to do more in terms of proceeding to endoscopy. On the other hand, if it's positive, that might prompt you to do different things and even adjust your treatment. If you look at C-reactive protein in comparison, it's quite the obvious. Now, also, if you look at the differentiation between UC and CD, you'll find that fecal calprotectin is probably more accurate in UC than CD. Now, again, when we set the pretest probability at different levels, you can see that the positive and predictive values of fecal calprotectin and C-reactive protein are different. For fecal calprotectin, the negative predictive value is quite good. Now, moving on to radiology. Similar to what Remo was talking about, the MR interrogatory is probably the most promising modality we have in radiology to monitor disease activity. This is a study that was performed in Barcelona by Jordi Remola. As you can see, it showed that there was a good correlation between MR interrogatory and ileocolonoscopy with a correlation coefficient of 0.82. As such, we think that MRE is highly accurate for the assessment of active disease. Now, it's really important to make sure that you use gadolinium when you use MRE, because the enhancement itself tells you a lot about disease activity. Specifically, when there's a stricture in the ileum, for example, you would want to know if the stricture is due to active disease or if it's fibrostenotic. Now, why do we choose the toughest target? Why go for mucosal healing or histological healing? I think this is a very important part of the treat-to-target approach. Now, starting with data from randomized clinical trials, we know from studies such as Act 1 and Act 2 that mucosal healing actually matters. As you can see, the risk of colectomy differs between different grades of mucosal healing. Similarly, in this slide, you can see that steroid-free remission at week 30 also differs. Now, if we look at CD as well, we'll find exactly the same results. Mucosal healing does predict future behavior of disease and outcome. This is data from a large cohort study from Norway, and you can see that even in cohort studies outside of the randomized controlled trial setting, which we can consider as an ideal setting and doesn't really reflect clinical practice on a daily basis, you'll see that also mucosal healing does predict colectomy in this type of setting. Now, if we were to choose to go a little bit deeper and choose a tighter form of control in the form of histological healing, we'll see that histological healing does in fact lower the chances of hospitalization and development of neoplasia or colorectal cancer, specifically in ulcerative colitis. So I think the question that most clinicians in the room will be asking at this moment, these are really nice data, it's good information, but can we actually do it in clinical practice? So I'm going to present some data to support that. First of all, data from randomized controlled trials, such as SONIC, for example, did tell us that about 44% of patients treated with combination therapy can achieve mucosal healing in this setting. Similarly, data from Extend with adalimumab after 52 weeks showed that about 24% of people or patients can achieve mucosal healing. And more recently, data from the Gemini study or vedolizumab, when you look at it from the intention to treat analysis point of view, in about 50 or even higher, 50% or 56% of the time did achieve mucosal healing. So we know from RCTs that we can, in fact, treat patients and target mucosal healing. Well, what about in clinical practice? So this is the treat to target concept in Crohn's disease that I would like to present. Similar to what Remo had mentioned, the concept itself is not new. It's been used in other diseases, specifically in rheumatoid arthritis, which is a chronic autoimmune disease that highly resembles UC, for example. You set the target from the beginning. After you do your baseline testing, you set your target with a predefined timeline, and you try to reach that target with repetitive assessments and reevaluation using objective markers of disease. This is a cohort study, a retrospective analysis done in San Diego that really reflects this concept in clinical practice. What they did is they tracked 67 patients with Crohn's disease in that center that were followed up for a full year. And they looked at the number of adjustments that were done over the span of that year and the number of endoscopies that were done. Now, between 4 endoscopies after baseline, as you can see, 72 different adjustments to treatment were made, specifically in TNF antagonist therapy related to introduction of therapy, optimization of therapy, switching within class and out of class. Now, the median time to adjustment that they noted, median time to reevaluation and adjustment was about 24 weeks, which is 6 months. The cumulative probability of observing endoscopic improvement was 15%, 54%, and 72% at 24, 56, and 74 weeks. With regards to mucosal healing, it was 12, 45, and 62%. So after 54 weeks, which is about a year, you know that about 50% of your patients can in fact achieve endoscopic improvement or mucosal healing. Now, when they did a regression analysis and looked at predictors of this improvement or mucosal healing, it wasn't related to a certain drug or dosage of a drug. No, the two significant predictors were the time that was taken between endoscopic procedures being less than 26 weeks and any adjustment in medical therapy within that time when there was absence of mucosal healing. So the fact that you use a treat-to-target approach in your management does guarantee you a higher chance of achieving mucosal healing after a year. When they did the exact same analysis in their UC population and was roughly the same number of patients, they found almost the exact same results with a cumulative probability of mucosal healing of 26, 52, and 70% at 26 weeks, 52 weeks, and 76 weeks. Now, histologic healing or disappearance of microscopic disease activity was also highly probable. It was observed at 19% at 26 weeks, 41% at 52 weeks, and 57% at 76 weeks. The predictors of observing mucosal healing and histological healing in the UC population was any adjustment in medical therapy and the presence of TNF alpha antagonist therapy at baseline. So based on that, the recommendation that was made is the treat-to-target approach, which was highly dependent on the re-evaluation period not being more than 6 months at a time. So how do we take this information and integrate it into a treatment plan in our clinical practice? Well, after we stratify our patients using available tools, we choose the appropriate treatment approach, that be step-up therapy or top-down, or even accelerated step-up similar to REACT. We then select our drug of choice based on our baseline testing, initiate therapy with the appropriate route and dosage, and after that, choose an objective measure of inflammation as targets, that being endoscopy. If endoscopy is not highly available, or there's some obstacles to using that, we can rely on objective measures of disease activity, such as fecal calprotectin or MRE. After that, we follow up our patients carefully and frequently with predefined time points to evaluate the targets, and based on the results I just showed you, the suggestive timeline is not more than 6 months. We then adjust our treatment to achieve that target frequently and repetitively until the target is achieved. And we always aim for tight control based on the data that I presented, that being mucosal healing. Thank you very much.